I'm just going to give an overview of nutrition interventions and kind of just considerations for both enteral feeding and parental nutrition. Okay, so just starting with the basics, nutrition assessment, you have your basic anthropometric measures, weight, growth charts. You know, again, I can't drive home how important it is to take height and weight at each clinic visit, and then, or even every, at least take the height and weight every clinic visit, but being sure to plot them over time. So you can see if a child is falling off a growth curve. We've heard about body composition, and then you have several biochemical labs, albumin, pre-albumin, kidney and liver status, as well as, again, you heard a lot about micronutrients already. There's secondary components of nutrition assessment, and why these are important will be more evident as I go through my talk, but certainly, what diagnosis the child has and what the impending therapy is important in terms of your decision of what type of nutrition intervention to initiate. Patients that we know are going to lose weight, have difficulty eating, there's really more of a proactive role to proactively intervene than wait till weight loss has occurred. And then there's a whole bunch of, socioeconomics, family support, et cetera, that go into kind of consideration. For example, if the patient's going to have enteral feeding, ensuring that the home environment is okay and there's enough support that the child is able to be fed at home. So in terms of how to calculate needs, in terms of how many calories a patient should have every day, how much micronutrients. The dietary reference intakes are really, I think, the general world standard in terms of foundation for nutrient evaluation. There is, again, as I mentioned earlier, institution and practitioner specifics or alterations that may occur. But what's important is that depending on your region, really looking for nutrient quality, making sure, for instance, in parts of the globe where vitamin A is deficient, make sure and screening for that, both for non-essential and essential nutrients, and then you heard a lot already about personalized medicine and nutrition genomics. So in terms of how to assess nutritional status, what indices to use, again, you all know height and weight, BMI I'm not going to go into, but what I want to bring your attention to are these last two, tricep skin fold and mid-upper arm circumference. And again, why these are important to do is because they can give you a sense of the breakdown in the distribution between fat and fat-free mass. They are very easy to do in the clinic setting, particularly mid-upper arm circumference. That really just takes a measuring tape to put around the child's arm, mid-arm, and gives you a number, and from that number you can basically classify their nutritional status. Tricep skin fold requires a caliper, and it requires, not all children are comfortable with it, but you kind of have to pinch the fat underneath here and then measure the inches, and again, that will give you a sense. But mid-upper arm circumference is quite easy to use. And there have been several algorithms that have been developed in order to prompt nutritional care. I believe you'll hear later about one that the PODC actually has developed considering the special needs of low and middle income countries. This was one that was developed by the Nutrition Committee of COG, and it really just prompts you through a sequence of events based on height or weight, crossing true percentiles, and of how patients how the care should be prompted. Now, I will bring your attention that this algorithm was developed maybe 15 years ago, and I hope what you initially saw from here was like, wait, we've been talking about body composition, and yet there's no indication on this algorithm. So This algorithm is in need of updating, but when you're looking at height and weight alone, it serves as a general reference. So what forms of nutrition intervention are available to you? First and foremost is always oral intake, and you really can't replace that with anything else. Having a diverse diet, helps keep the gut healthy. With this huge explosion in the microbiome, we know that diet quality, particularly dietary fiber, helps colonize the gut and keep it happy and in kind of a homeostasis state. And to help patients do that, make sure that a good antiemetic regimen is prescribed. Appetite stimulants, despite their limitations, are used when indicated. Then you have therapeutic diets, neutropenic diet. The ketogenic diet is getting a lot of press around the globe. I think both in pediatric and adults with brain tumors are asking about this diet. There are several clinical trials going on in Europe and the US looking at the efficacy of this diet. Some other diets are the glycemic diet, which basically limits the spike in sugar as a low simple sugar diet, not a low sugar diet, a low simple sugar diet, and prevents this huge spike in sugars. And then we have advanced nutrition interventions, so any type of nasogastric, enteral feeding, and then TPN. So in terms of ready-to-use supplements, this is really when you're kind of going through the step-right process in your head. You have a patient that's at risk of losing weight or going to lose weight, fostering and enhancing nutritional intake with supplements is really kind of your first line of defense. They're easy to administer. There's low burden for everybody involved. The big challenge with these are, will the child eat or drink them? So there's several things on the market. This is really a international representation. This is Central America. This is kind of globally, but more for Africa, Asia. Nutritia has some products, and then there's things like Carnation Instant Breakfast as well that can help boost, or even just any sort of protein powders that can help boost protein and caloric intake. There have been studies that have looked at the efficacy of homemade supplementation versus ready-to-made supplements. And this becomes important, particularly in low and middle income countries where the child may have a nasogastric tube, and while they're in the hospital, they have access to the feedings, but when they go home, they have to make the feeds themselves. So there's been 2 studies from Brazil that have looked at the efficacy of homemade dietary supplements in maintaining weight gain or promoting weight gain, and they found them equal. What I think is, again, thinking of diet quality, what's nice about doing homemade supplements is that outside of their cost, that you can really control diet quality a little better. So using more salubrious nutrients to help increase the exposure to real fruits and vegetables, utilizing things like coconut milk and water to help administer electrolytes and vitamins is also added plus about homemade supplementation. This is a sample of a homemade supplement that's used in Brazil. Karina Vianney is a registered dietitian in Sao Paulo, Brazil, and has a homemade supplement mixture that she has measured out and given to parents. And usually there's like a variation of this, sometimes with or without meat, and a variety of vegetables. You see onions for flavor. Really, MCT oil is often the oil that is used here. In Brazil, there's a lot of access to coconut oil, which has medium chain triglycerides, so those are absorbed very quickly into the body, and the children don't have to metabolize them. It helps promote weight gain. And there's been many variations of this kind of around the globe. Just the idea is to really use local foods to help augment intake. Many places have asked about, or kind of one of the most common questions I get is, do patients really need to follow a neutropenic diet? And, the answer is it really depends on where the patient's living, what the home environment is like, and whether they have access to things like clean water. So this was a study that was conducted at St. Jude's, and it was led by Teresa Mosby, who's a registered dietitian and clinical investigator, and they developed a neutropenic guideline tool for illiterate families. And you can see from this, really it's very easy for families to follow. It's kind of like an X means no, and then all of these other areas are yes. And so they've had quite a lot of success in, it's more about food safety versus the neutropenic diet per se. But again, that really depends on the hygiene of the home environment and what patients have access to. So what I'm going to focus on now, I'm kind of moving forward, is really enteral nutrition. And if there's one message I can drive home today, is that enteral nutrition really should supersede the use of total parental nutrition almost on every occasion, with a few exceptions. It really has been demonstrated to not only be safe and feasible in children with cancer, even in the setting of thrombocytopenia, even in the setting of highly metagenic regimens, to just be better in terms of infections and complications. So why is it better? Again, I talked about preserving gut function, and as we learn more and more about the importance of the microbiome, this is essential. Talking about decreased risk of infection, the effect on the liver, there is no effect on the liver versus TPN. Ultimately, if they're on TPN long enough, you'll have elevated hepatotoxicity. Certainly, the cost and administration is particularly important for low and middle income countries. So some general criteria are greater than 5% weight loss from pre-diagnosis weight. And I have severe xerostomia, but really it could also be severe mucositis, anything that's going to really prevent the child from eating during therapy. And what I want to bring your attention to is really this last point, is that regimens with expected weight losses, we know that for certain diagnoses, certain brain tumors, solid tumors, almost all of them, especially those with advanced disease, they will lose weight, and they usually will lose a significant amount of weight. And the push towards really proactively feeding is where the field needs to go. There are barriers to enteral feeding. Patients can refuse, the child can refuse, the parent can refuse. This is especially in older children, although every, I think, child that we've ever put in a nasogastric or gastrostomy tube in, after they've had it, the parents are usually happy because they don't have to argue with their child about eating anymore. There is still a lot of clinician either support or lack of for enteral feeding, and this isn't just physicians, this is nurses, this is dietitians, it's really across the board. And that's really drives home that we need more education on the importance of enteral feeding. Talked about the planned regimens. There is a lot of controversy, I would say, about just what GI conditions can you actually use the gut in, and what do you have to give the gut a rest. And we had at our previous workshop an interesting lecture on that in Jordan, and then certainly recurrent infections, how to manage enteral feeding when a patient's just getting recurrent infections. Usually that's with a gastrostomy tube, not so much with nasogastric tubes. So you really kind of want to balance when you're thinking about the best nutritional care, what's the best evidence, your clinical expertise, which we're hoping by these kinds of workshops, we're elevating that, where you know more about enteral nutrition, and then what are the patients going to expect from this. So I'll bring your, there have been few studies performed in children with cancer and enteral nutrition, but this one was a small prospective pilot study in children with a variety of diagnoses. And really the significance of this study was really determining safety and feasibility. So what they found was that enteral feeding is safe in children at high risk for nausea, vomiting. What they also found that there's a significant cost savings. Now this number is US costs of between TPN and enteral feeding, but really there was a significant cost savings to the institution. There also have been trials that have looked at what the prospective, what the effect is on preserving nutritional status during therapy. And this was a study that was conducted again in patients with a variety of tumors, but with expected weight loss. And what they wanted to look as, can proactive enteral nutrition prevent the weight loss? And what they found was there was less weight loss in the enteral nutrition group, and that there was improved nutritional status by the end of the study in the group that received intervention compared to no intervention. Now this study did have observed an increased risk of increased infections in the enteral group. However, there was some suggestion that it may have been driven by the AML group and a particular regimen they were using at the time, because this is the only study that's actually really found that there was this slight risk of infections in this particular cohort of group, and this was done at Children's Hospital of Philadelphia. So in terms of gastrostomy tubes, I mean, I think especially older adolescents like it better compared to a tube hanging out of their nose. I think the problem is for low and middle income settings is having a surgeon who knows how to place a gastrostomy tube and knows how, a clinical staff that knows how to manage one. And so again, there have been several studies. I'm going to kind of gloss through these. You can read through these, but I think clinician education is really essential prior to its use in any sort of clinical setting. And again, I think that's where these sessions kind of come in handy, and really more evidence is still needed looking at the beneficial effects of gastrostomy tubes. So prior to initiating enteral feeds, what do you need to consider? Again, access to materials and devices, the formula, the tubing, formula we covered, what type of tubing. So usually tubing goes by ages, but I've seen all kinds of different size tubes used all over the globe, whether or not you have access to pumps. However, with pumps, it really, you can, it's not a rate limiting factor in initiating any enteral feeds. There's several ways to get around that. If you do not have a pump, syringe feeding, as long as the patient tolerates it, is perfectly fine and perfectly acceptable to get feeding into the patient. You can also use gravity feeds. And so really, obviously this takes a longer period of time and certainly is not as fast as a pump, but still works without having the pump kind of calculate the nutrients going in over time. And this is just a schematic demonstrating how that can be done, and this can be done, what's important about this, it can be done in the home setting. So very few institutions in low and middle income countries have pumps that they can give all of their patients on enteral feeding to take home. And this is really two strategies around those barriers. Okay, so required clinician oversight and management, again, making sure that you have availability of antibiotics, and you do need experienced staff in initiating and managing enteral feeding. The family education is also important in making sure that the family can adhere to the guidelines. The more families you have on enteral feeding, the less burdensome I think this is on the clinician, because the families talk to each other and help each other. So it's not necessarily something that falls solely on the clinician. And again, I mentioned environmental hygiene. So I have 15 slides on enteral nutrition and one on TPN. And really, there was a Cochrane review recently that looked at the use of parenteral nutrition, in terms of preventing malnutrition toxicities, et cetera. And really, they found limited evidence to suggest that PN is more effective than enteral feeding in well-nourished children with cancer. And more importantly, is that the routine use of PN during chemotherapy, radiation, or combined therapy is not recommended. And I believe this Cochrane review is being updated and that the results are the same, and that really the use of parenteral nutrition is just not recommended unless there's a few clinical conditions. And even these are controversial. You know, I've kind of already talked about mucositis, so severe pancreatitis, radiation enteritis. There's some, generally speaking, enteral feeding is not used, but I know that there's some clinicians that actually think feeding very little enterally is actually helpful for the gut. Any obstruction, I think, is pretty much, you can't use enteral feeding. And intractable nausea and vomiting, you know, we don't really see those patients anymore, but where they absolutely can't stop, but that would be an indication if you did have a patient like that. You know, some other clinical, when a period of no or minimal enteral nutrition is taking place. Again, this is really coupled with some other clinical condition. Would TPN be initiated? And what's important, that is if you need to use it, that when the GI tract is functioning, that there needs to be a nice transition back to enteral feeding. So thank you very much, and I think we'll move on to the next speaker.